let's pick up where we'd left off. We were talking about the regularity of a rhythm. So you can have a regularly regular rhythm, you can have a regularly irregular rhythm, excuse me, or you can have an irregularly regular rhythm. So ultimately, you're looking to see if there's some type of consistent pattern among the rhythm to provide you some regularity, because it might be an irregular rhythm, but is it occurring regularly? For instance, is your patient having PVCs every couple of beats, or you having PVCs every third beat or something to that effect? You may get into bigeminy or trigeminy, anything of that nature. So to assess the overall regularity, one of the things you can do is assess your R to R interval. You could also assess your P to P interval. So if our R to R interval to start out here is about 2.5 boxes, so 2.5 large boxes. Remember, we talked about the difference between our large and small boxes. So the R to R interval between these two, pretty much right on the money at three large boxes. So you went from 2.5 to 3. Now we're down to a little over 2.5, so maybe 2 3/4. And then you got 2 and 2, so maybe close to 2.5. Then there's 3.5, 3.5, 3.5, 4, back down to 3. So if you're looking, and by the 3, 3.5, 2.5, I'm just looking at the amount of the large boxes in between your R to R intervals. So we'll look at that. I think we calculated based upon the 6-second method. We utilized the 6-second method earlier. Remember, these are our 3-second tick marks. So this is full 6 seconds of time right in here. So you can count the complete number of R waves that you have in there, multiply that by 10, and that'll let us know what the ventricular rate is. So our ventricular rate, based upon the 6-second method, is about 100 beats per minute. Beats per minute, BPM. The atrial rate with this particular rhythm, we can't really discern any P waves. So atrial rate, not necessarily applicable. Looking at our P waves or how they're shaped, not applicable. Our QRS duration, if we're assessing the QRS duration, your QRS duration should be less than 0.12 seconds or 3 small boxes. So if you go up here and look, these QRS complexes shouldn't be any wider than 3 small boxes, and that's 1, maybe 1.5, 2 boxes, 2 boxes, 2 boxes, 2 boxes, 2 boxes. So our QRS duration on average is about 0.08 seconds, because remember, each one of these boxes represents, each one of these small boxes represents 0.04 seconds in time. The regularity, it's not occurring regular, so I'm going to say this is irregular. Your PR intervals, you can't find the P intervals. So in order to measure your PR interval stuff, you had a ECG, then your PR interval would be from the start, let me get a little closer, start of the P wave to the start of your R wave. So this area here would be your PR interval. And you want your PR interval to be less than 0.2 seconds or 1 large box. One large box. So our PR interval, we can't really find that there. The QT interval, the QT interval, if we're looking at an ECG tracing again, P wave, Q wave, R wave, S wave, T wave, the QT interval would begin pretty much at the start of the Q wave, and would polish off or finish at the end of the T wave. So this distance here is our QT interval. The QT interval may vary depending upon, from rhythm to rhythm, but ultimately, if your QT interval becomes prolonged, that could indicate that you've got maybe getting ready to get into more ventricular dysrhythmias or anything of that nature. So we're going to leave that blank for the time being. But again, your QT interval would begin at the beginning of your Q wave and stop at the end of the T wave. So we look at the overall dysrhythmia. Well, because this is multiple choice, we've got a few different things to look at. We've got atrial fibrillation. One thing to make note, when you have atrial fibrillation, you'll have no discernible P waves with atrial fibrillation. And one of the things that we want to make mention of too, if we have, so we know that we've got the heart. The heart is an object that sits in the chest, and you've got the atria on top and the ventricles are on the bottom. So typically through contraction, you've got the atria will contract and then the ventricles contract. So kind of that motion all together. And when you listen to your S1, S2 center, your lub dub, you'll tend to should be able to hear that. So nonetheless, your atria and ventricles should fire in sequence with each other so that the atria ejects blood into the ventricles and the ventricles eject blood up in the pulmonary circuit into the systemic circuit like it's supposed to. What happens is if you get into a scenario where you've got atrial fibrillation, so basically fibrillation just means quiver. So the atria now are sitting on top of the ventricles and quivering, all the while the ventricles are still trying to contract and move, and they can. So I mean, not that they're just trying, but they are. You can live with atrial fibrillation. You're not going to live with ventricular fibrillation. So if we get to a point where the ventricles begin to quiver, well, now you've essentially got no cardiac output going to your lungs or going out to your body. You're like, well, if you can't live with ventricular fibrillation, why are you living with atrial fibrillation? Under normal circumstances, although the atria are contracting in a coordinated fashion with that, the bulk of the blood flow from the atria goes into the ventricles by way of gravity anyway. So even if these things are just kind of quivering, as long as each atria is continuing to receive blood, by gravity, blood is still going to go down to the ventricles. So when the ventricles contract, it'll still be able to pump blood effectively up into the pulmonary circuit from the right side of the heart and into the systemic circuit from the left side of the heart. But if your atria are in a position where they're just contracting, where they're fibrillating, then they're not going to be in discernible P waves when we go to look at our ECG monitor. And up here, we see that there are no discernible P waves. Some of these variations might make us think that there's some P waves, but there's also a really thick line, and you're not going to see, and you've got an irregularity to it as well. So based upon analyzing this rhythm and looking at it, I'm thinking that atrial fibrillation is definitely a good choice. We'll look at atrial tachycardia. In order to deem something atrial tachycardia, you would need to be able to count the atrial rate. And in order to be able to count the atrial rate, you would need to be able to see the P waves. So I'm marking that one off. This is not a wandering atrial pacemaker. I'll mark that one off. And if this was a sinus tachycardia, so remember a normal heart rate. So a normal heart rate is 60 to 100 beats per minute. And we also note that if we have a sinus rhythm, then, so if this was sinus tachycardia 1, our heart rate would be greater, than 100 beats per minute. And then we would also have a P wave in front of every QRS complex. And we don't have that. So through process of elimination, we can mark that one out as well. So because we're looking at analyzing these rhythms as opposed to trying to memorize what they are, we can go through these and pick out what the rhythm is. So this is atrial fibrillation. And before, and I'll talk about rate when we get one that where you have the ECG tracing upside down. So remember in class, let me clear this drawing, all the drawing right quick. Remember in class, we talked about you have some ECGs that are right side up, some ECGs are upside down. So for instance, if we go back and we draw the stick figure like we did on the board, we know this is the patient's right over here, patient's left is over here. You know that you've got an electrode here, an electrode here, an electrode here, and an electrode here. Those are going to help create your augmented leads as well as your standard limb leads. And then you've got V1 through V6. V1 through V6. So your 10 electrodes create the 12 leads. And remember, we said that with the heart being oriented kind of this direction, that our overall wave of depolarization is going to move for the most part in that direction. So if you have a positive electrode, and that wave of depolarization moves toward the positive electrode, then you're going to get an upright deflection or a positive deflection in your ECG. So your ECG will be right side up. If the way, like for instance, if we were to create this and make this AVR, augmented voltage right, then the right arm now becomes positive while the heart serves as a negative reference point. This wave of depolarization moves away from that positive electrode. So therefore we can anticipate an upside down or negative deflection ECG, much like we see up here. And then before we move on, let's talk a little bit more about rate. So we had talked in the other part about calculating rate. So we did the 6-second method. We talked about how to come up with the time in which you have on the ECG paper for 6 seconds. So here, because we can only see our R waves, there's no P waves to discern, we found that there were 10 complete R waves within the 6 seconds. So via the 6-second method, we got 10 R waves multiplied by 10 because it's 6 seconds a time. So that gave us an approximate rate of 100 per minute, 100 beats per minute. Now remember, we went up here and we found the rule of 300. So we found this R wave and we found this R wave. There are 3 large boxes between, so utilizing the large box method or the rule of 300, then you can take 300, divide that by 3 to estimate what your, so you take 300 and divide it by the number of total boxes that you have between the two your RR interval. And then that's going to give you an approximation of what the rate is. So our 6-second method tends to agree with this particular calculation here. If we utilized this same RR interval and we utilize the rule of 1500, then you would take 1500, divide that by the number of small boxes within that range. There's 3 large boxes and 5 per large box. So that's 15 small boxes. 1500 divided by 15 again is 100. I wrote 1,000, but I just meant 100. So it's 100. So again, we're looking at 100 happening there. So that's the rule, the 6-second method, the rule of 300, and you have the rule of 1500. Rule of 1500 can be the small box method. Rule of 300 can be the large box method. And then we'll also cover something called the sequence method. So if we were going to utilize the sequence method, again, you want to find 2 RR intervals that fall pretty close on some heavy lines. So you find one, this is the one we're going to use. And then what we'll do is the next one over, we're going to write down 300 on the next heavy line over. Then we'll go to 150. And then the next heavy line over is going to be 100, then 75, then 60, and then 50. And then ultimately where that next R wave falls is going to be an approximation via the sequence method what your rate is supposed to be. So by doing this measurement here with the sequence method, we get 100. So we've got now have 4 methods of rate calculation that have all come up with 100. And that's all well and good as long as you have a regular rhythm. When you get into your irregularities, like for instance, if we went over here and did those calculations, then 6-second method, with 6-second method still shows us or demonstrates that we have a rate of 100. Our rule of 300, let's see here. So if we have 300 divided by 4, that would end up being 75. So that's rule 3. And then if you did 1500, then there's 4, there's 5, so that'd be 20. 1500 divided by 20, that would still be, we double check the math on the calculator right quick, but I'm still pretty sure that's 75. And it is indeed 75. So then if we were to utilize our sequence method, and let me clear these drawings here, that way. So if we're utilizing this R to R interval right here, if we utilize this R to R interval, remember you're going to go with 300 on the next heavy line after finding the R interval on the heavy line. Then you go 150, 100, and 75, and then you knock that back down to 60 and 50. But really, you wouldn't need to extend that far out because this next one drops here, so you can see that that's 75. So with an irregular rhythm, it would really depend upon where you measure that at for what the rate is. So to get more precise, when you start doing math, you're going to have a more favorable rate calculation. But generically, you can utilize the 6-second method to give you a decent approximate rate of what your ventricular rate would be. Remember, you're counting your R waves for the ventricular rate, your P waves for the atrial rate. So let me clear this and then we'll move forward. So it is atrial fibrillation. So now if we'll look at this particular one, this particular rhythm, first and foremost, one of the things that I want to make sure that I stress to you is you want to make sure that you ask with any of these rhythms that you might see if the patient has a pulse or not. Because if the patient doesn't have a pulse, then it's possible that you've got pulseless electrical activity. Now, there's one rhythm that you'll absolutely not ever have a pulse with, and that is ventricular fibrillation. If it's true ventricular fibrillation, there'll be no pulse associated with that, and you'll call it ventricular fibrillation. But if I had an organized rhythm up here and it was like a normal sinus rhythm, but there was no pulse, then essentially I would be in what's called pulseless electrical activity, or PEA. So you absolutely need to make sure that you ask to make sure that your patient, if they have a pulse or not. So when we look at this particular ECG, notice that it looks pretty uniform in shape. Everything's eyes pretty regular. So I mean, this is fairly regular in regard to the regularity across. Is this like a normal type rhythm? No, but we can look at that as we go. Our PR interval, there's no discernible P. We're not able to see any P waves, so I can't see that. Can't look at the P wave over here. Can't see that. QT interval, that's not really appropriate here either. The atrial rate, you can't see the atrial rate, so we're not going to be able to calculate an atrial rate. If we look at the ventricular rate, look at your R waves. And remember, they got it. So for instance, this one gets cut off by this. So with a 6-second method, I can't utilize that one. So if I go up here and I count them, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17 times 10. So that gives me a ventricular rate of about 170. If I look at these QRS complexes, and look at the distance between those two. So there's one whole box, and so like 2 small boxes. So you say maybe one, so maybe 7 boxes, and they're all so 0.04 times 7. And that'd be what, 0.28 seconds. And your QR interval is supposed to be less than 0.12 seconds, or three small boxes. So your QRS complex, so this is wide, be wide, or you could go ahead and write in your number because you calculated 0.28. So knowing what we know about the rhythms, we know that this is, we see in our ROs, so it's a ventricular rhythm. It is tachycardic. We'll say that the patient has a pulse, so this is ventricular tachycardia with a pulse. Specifically, this is something called monomorphic ventricular tachycardia. And it's monomorphic because these are uniform in shape. All these are uniform in shape. If it was polymorphic ventricular tachycardia, you would have almost like a helical DNA strand about it. It would get really wide, then narrow, then wide, then narrow, then wide, then narrow. So we'll hold off on that. But this is monomorphic ventricular tachycardia based upon everything that we're looking at. And we did ask the patient has a pulse. So we're going to look at ventricular tachycardia as our ventricular tach Tachycardia. Ventricular tachycardia as our dysrhythmia. So now we'll look at the answer choice. Is this atrial flutter? No, it is not atrial flutter. Is this an accelerated idioventricular rhythm? It is not. Is this ventricular tachycardia? It is. Specifically, it's monomorphic ventricular tachycardia. Is this an SVT? No, it is not. So the only answer that makes sense here is answer choice number 3, and that's because we've taken what we know about ECGs and we've applied the analysis to the rhythm, and we're able to come up with that. So I'll clear those drawings, turn that off, then we'll move on to the next one. So you can see that that is ventricular tachycardia. So now what we'll do is we'll look at this particular rhythm in the same fashion, same shape that we've done all others. So if we were to look at our one, we're going to ask, does the patient have a pulse? Yes, the patient has a pulse. Let's look at our RR intervals. So our RR intervals, you got 4 boxes here, you've got 4 boxes there, 4 boxes there. Now there's what, 6 boxes in between there, 4 boxes and roughly 4 boxes. So for the most part, I mean, there might be some irregularity, but for the most part, we'll call this a regular rhythm. Now we'll look at our ventricular rate utilizing the 6-second method. 1, 2, 3, 4, 5, 6, 7. So we're going to look at about a ventricular rate of 70. Now, when you look at your P waves, you're looking at these delta waves or your flutter waves that get in between there. And notice that this takes on the shape of like the serrated edge of a knife or the serrated edge of a saw. So if you have a sawtooth pattern, you can pretty much bet that you're going to be looking at an atrial flutter, especially if you've got these little flutter waves and your delta waves in there. So if you were to count all those as extra P waves, you would find that your ratural rate is much higher than that of your ventricular rate. So that means that we could be in a situation of atrial flutter. The PR interval, you know, you're choosing the one closest to, I mean, it's relatively, it is smaller than one large box if you're looking at the PR interval that, at the P wave that coincides with the R wave. The QT interval, can't really see that at the moment. So the dysrhythmia, I'm going to go with flutter or atrial flutter specifically here. So sinus tachycardia, if it was sinus tachycardia, again, you would have a P wave in front of every QRS complex, and your rate would be over 100 beats per minute. This is, we've established that our ventricular rate is 70. We're going to, a sinus dysrhythmia, this falls more along the lines of atrial flutter, so we can dismiss sinus dysrhythmia. Atrial fibrillation, well, you see a bunch of flutter waves and delta waves, and you see the P waves occurring before the QRS complex. So we'll mark that out and leave it with atrial flutter. And atrial flutter gives you a sawtooth pattern. So if you happen to see that, then that's what you'll be looking for on your ECG rhythm recognition exam. So now let's look at this particular rhythm. So if we look at our regularity, it appears to be fairly regular. Then if we look at our PR interval, well, you know, you pretty much got the T wave in here. The P wave could very well be buried in that T, but it's hard to really kind of pick it out. So can't really determine the PR interval. Hard to really tell the measurement of your P waves. Your QRS complexes, the duration of your QRS complex is less than 0.12 seconds. So that's actually, you know, on average, it's about 1.5. Well, we'll just call it 0.04 because it's about 1 box in between each one of those. 0.04 seconds. Look at the QT interval. So, you know, look at Q and, you know, that would be the Q to the T. So not necessarily important per se what we're doing at this particular moment, but if we count the ventricular rate, well, again, going to be difficult because the P's might be in there at the tail end of that T wave or what have you, but nonetheless, let's go ahead and count the ventricular rate. And our ventricular rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So it's 200. So the ventricular rate is 200 beats per minute. Pretty much any heart rate over 100 is going to equal some type of tachyrhythm. Now, if you can look at a P wave in front of every QRS complex, then you know that you would have a sinus tach rhythm. When your heart rate gets up above 170 and you kind of lose the ability to find those P waves, then we're looking at an SVT or supraventricular tachycardia. And if it's sustained, you know, the heart rate's going to be fast. Patient may feel like their heart's pounding or fluttering within their chest a little bit. Some things that you might do to correct this would be have the patient bear down like they're trying to have a bowel movement. That should stimulate a vagal response, and stimulation of the vagus nerve should slow the heart rate down. You can also do carotid massage if you want to. Don't do both at the same time. Just do one carotid artery, carotid massage. That'll help with those baroreceptors in the neck. That could help also decrease heart rate. If it were a kid, you could have them try to blow through a straw. That would again cause vagal stimulation. You could take an ice pack, put it up against their skin. That would again cause vagal stimulation. You know, pharmacologically, if you want to try to cardiovert this, then you would utilize the administration of adenosine, or you would have to do synchronized cardioversion to get rid of that. So looking at this, when we're looking at SVT or supraventricular tachycardia is our rhythm here. So now let's look at this particular rhythm, and we'll see that you have more P waves than you do QRS complexes. So we have a relatively slow ventricular rate. Our ventricular rate stands out pretty quickly. It's 40. For utilizing the 6-second method, it's 40. Our QRS duration, so if you look here, it's right at 3 boxes, 0.12 seconds. So we'll call our QRS duration 0.12. Is it regular? Our PR interval is fairly regular. So it does seem to be occurring. Our QRS complexes seem to be occurring on a regular type basis. Our atria, now if you look at the P waves, so our P waves, you've got what's called an unconducted P wave here. So you have a P wave right here that has nothing after it. There should be a QRS complex after here. When you start looking at rhythms that have P waves by themselves or an extended gap in your PR interval, you're looking at some type of atrioventricular block or delay. So by knowing that, we can automatically go ahead down here and knock out that one, and you can knock out that one, because we know that we're going to be looking for some type of heart block that we have. So there are a couple of rules with the blocks that we need to make sure that we look at identifying. So what are the type of blocks? You've got first degree, and basically what's going to happen is with first degree atrioventricular delay or first degree atrioventricular block, you will have a P wave in front of every QRS complex, but your PR interval will be greater than 0.2 seconds. And that will be consistent from beat to beat. Then you have second degree type 1, second degree AV block type 1, also referred to as Mobitz 1 or Winky block. And basically you're going to get a prolongation of your PR interval until one P wave finally fails to conduct to the ventricle. So then you have a P wave by itself. Then you have second degree type 2 or Mobitz 2. And for here, you're going to have a normal PR interval. Normal PR interval, and you'll have a P wave in front of every QRS complex, except every once in a while, you'll have a P wave standing alone by itself. Then you're in second degree type 2 or Mobitz 2. And then you can have third degree heart block, third degree atrioventricular block, third degree heart block, or complete heart block is what it's referred to. So then you're going to have a slower ventricular rate, and the atria will tend to kind of do what the atria want to do, while the ventricles tend to do what they want to do. So there will not be much not much conversation or much rhythm, if you will, or pattern within this. So if we're looking at second degree type 2 versus third degree atrioventricular block, if you look at second degree type 2, with our definition that we would have normal PR intervals, there's really only one up here that has a normal PR interval, and that's this one here. So if we were to look here, our PR interval extends beyond one large box there. So it's a prolonged PR interval here, normal PR interval here. Then you got what, 2.5 boxes there. We go. So some would look at this too and think, well, maybe it's a Winky box. Maybe it's second degree type 1. Do note that with the second degree type 1 or a Mobitz 1 or your Winky box, you will have that prolongation. So you may start out normal, then you get a prolongation over the course of a couple of beats where your PR interval continues to get wider and wider and wider until finally you've got a P wave with nothing by itself. So ultimately, if we look at this particular one, so if we were starting here, we have a PR interval that's not normal. Then you have a P wave by itself. You go back to normal P wave, PR interval, and then you have an abnormally wide PR interval. And there's really, so second degree type 1, the rules for that doesn't necessarily fit. Second degree type 2, when you have a QRS complex, you should have a P wave in front of it. The PR interval should be normal with standalone P waves, and that doesn't really match. So I have a relatively slow ventricular rate. We've already established that at 40. So now if I'll clear all this off, we should find that when we pull up the correct answer, we're looking at a third degree atrioventricular block. And that's the correct answer based upon the rules that we went over with that. So now let's take a peek at this particular ECG. So if we're looking at this ECG and we're analyzing them, does the patient have a pulse? Yes, our patient has a pulse. So let's look at our atrial rate. You got a P wave here, a P wave here, P wave here. It's 3, 4, 5, and 6. So multiplied by 10, our atrial rate is 60 beats per minute. Our ventricular rate, you've got a QRS complex here, 1, 2, 3, 4, 5, 6, is 60. So you have a P wave in front of every QRS complex. So, does the rate fall within 60 to 100? It does. Some people, and is it regular? It is regular. Yes, it is. When you look at your P wave, your P waves are normal. Your QRS duration is 0.08 seconds. It looks like, because about 2 small boxes, so 0.08 seconds. QT interval is good. The dysrhythmia, though, so a lot of people would jump on this maybe and call it a normal sinus rhythm, but you got to make sure you look at your PR interval. So if we look at our PR interval, this extends out further than one large box, and that is consistent from beat to beat. I mean, you've got a PR interval that's greater than one large box in every. So if you remember the rules that we just talked about, then you know that we're looking at a first degree atrioventricular block or first degree atrioventricular delay. So this is first degree. It's not second degree type 1. If it's second degree type 1, your PR interval will get longer and longer and longer until it dropped. And we don't see that here. So going through and analyzing the rhythms, we can find that this is first degree atrioventricular delay. So let's take another peek at this one, utilizing the same stuff. So if we're looking at our atrial rate, let's count our P waves. You've got a P wave here, here, 3, 4, so 4, 5. Let's see. So it looked like maybe our atrial rate possibly 50. Ventricular rate is 50. Regularity seems to be fairly regular. Let's look at our PR interval. Our PR interval here is in excess of one large box. Then it's normal here. So if you're looking at your PR interval being normal here, then it's 3 boxes, then it gets shorter, and then it's shorter. Well, then it happens to be kind of normal. So there really doesn't seem to be much of a pattern with a longer drop type rule. So if I were looking at this and my QRS complex, now they're a little wide, 1, 2, 3, 1, 2, 3, maybe 3.5. So we'll call that 1, 3.5. So we'll call that, roughly 0.12 seconds, maybe a little bit wider than that. It could be 0.14. So 0.12 to 0.14 or 6, 0.12 to 0.16. The QT interval would be, relatively within range if we're looking at that. And our PR intervals, they're not consistent from beat to beat, but now we've got to decide. So we know we're looking at some kind of block. It's not sinus bradycardia. It's not sinus rhythmal PVCs. So now we got to decide if it's third degree atria. We do have a slow ventricular rate. It does appear that the atria are kind of firing at will when they want to. The ventricles, the atria are firing at will when they want to. The ventricles tend to fire at will when they want to. Now we look at second degree type 2. So if this were second degree type 2, we would be saying that for every QRS complex, there's a P wave in front of it, and then every once in a while there would be P waves standing by themselves. Well, here we only got 2 QRS complexes with a P wave in front of them, so I think it's just coincidence that it fires off like that. So this leads me to believe that we're looking at a third degree atrioventricular block rather than a second degree atrioventricular block type 2. So based upon everything we know and applying what we know to these rhythms, we'll look at it and test it here in just a second, see what we've got. And it is a third degree atrioventricular block. So let's get the pen out and get ready to go again. So now let's look at this particular rhythm. Let's look at our atrial rate. If we count our P waves, that looks like it could be a P wave. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we got a based upon the 6-second method, an atrial rate of about 100 per minute. Ventricular rate, we see 40. So we got a relatively slow ventricular rate here. We are having more P waves, it appears, than that. Are things occurring regularly? It does appear to be regularly irregular in that we have, QRS complex, P wave, nothing after, QRS complex, P wave, nothing after, QRS complex, P wave, nothing after, QRS complex, P wave, nothing after. Our P waves are they are abundant, but they appear to be normal in size and shape. Our QRS complex, roughly 0, there's one small box, so 0.4 seconds in duration. Our PR interval is less than 0.2 seconds with is less than 0.2 seconds when we do see that we have. So we do have a P wave in front of every QRS complex, but we also have some P waves that are normal. But notice we'll go back to this and we'll see that our PR interval is normal when the P waves show up with the QRS complexes. So we've got that. And then we'll find that we have standalone P waves. So this is definitely the definition of second degree atrioventricular block type 2 with what we had just gone over. It's not first degree AV delay, because if it was first degree AV delay, you'd have a prolonged PR interval and that'd be consistent from beat to beat. It is not. Although this is a Brady rhythm and some might jump on sinus bradycardia, it is not just sinus bradycardia, but instead it's sinus, it's second degree type 2 atrioventricular block, or type 2 based upon what we know about it, and it's not multifocal atrial tach. So we clear that and we'll take a stab and see if we were right with second degree type 2. And we are. So again, we've already seen one like this. So we'll try to be relatively brief. You can see that you've got your flutter waves, your delta waves in here, your regularity. Your R waves tend to be occurring appropriately. You've got 3 flutter waves, it looks like, in between each one of those. So definitely have more flutter waves than you do your R wave. So this is not atrial, and it takes on the sawtooth pattern or the serrated edgment. So you're looking at atrial flutter here. Now we'll take a peek at this. I am going to pull the pen back out on this one just because it take a little bit of time to go through this. So if we let's look at our atrial rate. So we got a P wave here, 1, 2, 3, 4, 5, 6, 7, 8. So roughly an atrial rate of about 80 beats per minute. So then if we look at our ventricular rate, we see our QRS complexes at 1, 2, 3, 4, 5, 6, so roughly 60. So we know that we've got a couple more P waves than we do our R waves. So we've got a little bit faster ventricular rate, a little bit faster atrial rate than we do ventricular rate. So that lets us know that we're going to be looking at some kind of block. So because of that, through the process of elimination, you can go ahead and take out 2 and 4. Go ahead and take out 2 and 4 because we know we're looking at some kind of block. Now we just got to figure out what kind of block we're looking at. Well, if we apply the rules, what we're looking at, so our regularity, this is irregular. Look at your P waves. Your P waves are normal when they show up. They appear to be normal in size and shape when they show up, so they're normal. QRS complex is 0.04 seconds. Appears to be about 1 small box. Your PR interval. Now your PR interval changes. It appears so it changes. QT interval going to be about the same and consistent from beat to beat. So we're looking at this dysrhythmia. So now we got to decide which block. Well, remember, first degree atrioventricular block would mean that you have a prolonged PR interval and that's consistent from beat to beat. So if you look, just circle 2 of those, you're not prolonged here, but you're borderline prolonged here. I mean, that's right at 1, I mean, it's right at greater than 0.2 seconds. So it is not consistent from beat to beat. So we can pretty much rule out first degree atrioventricular delay. And if we happen to look at this, we'll see that our PR interval is, let's see. So if we're going from here, so it's 4 boxes, that's 5 boxes. So that's 0.2 seconds. Then if we're going, well, maybe 0.24 seconds here. Then we're going, you definitely got a whole box here plus 3 more boxes. So then it's long. So your PR interval got bigger from this beat to this beat. PR interval got bigger. Now all of a sudden you see this P wave on the end of your T wave where there's no QRS. There's an empty QRS complex. So there's here. So longer drop. Normal QRS complex, a little bit longer, or normal P wave, PR interval, a little bit longer PR interval, a little bit longer PR interval, and you get so longer drop. Now you have your Winky block, or your second degree type 1 block, or your Mobitz 1. So that's going to be the correct answer on that one. Take a peek at this one. Does the patient have a pulse? Patient has a pulse is weak and thready. Your ventricular rate is 40. Ventricular rate is 40. Atrial rate, so P wave here. So it's 3, 4, maybe 5, 6, 7, 8, roughly 80. Regularity. The ventricles seem to have, some variation between two. You're a little bit longer here and shorter here, then you get a little bit longer. So we'll call it an irregular rhythm. Your P waves are normal in size and shape when they tend to appear. Your QRS duration is about 0.08 seconds. PR interval. So over here you have, if this P is married to this QRS complex, it's greater than 0.2 seconds. Then immediately we can follow that with a P wave by itself, and then you've got borderline 0.2 seconds to a little bit longer than 0.2 seconds, and then you're right back to where you were longer than that. So there's really no consistent pattern. So we know we can see P waves. So we knock out atrial fibrillation. We know it's not a normal sinus rhythm. You know it's not first degree atrioventricular delay because there's not a first degree. There's not a pattern for first degree. So you got a relatively slow ventricular rate. So we are looking at third degree heart block in this particular situation. Now we'll look at this one. Ask, does your patient have a pulse? Yes, your patient's got a pulse. So let's look at everything else. Our atrial rate, let's look at the P waves. 1, 2, 3, 4, 5, 6. Atrial rate is 60. Our ventricular rate, 2, 4, 6, is 60. Regularity, we are regular. P waves, they are normal for their size and shape. Our QRS complexes, we are right at about 0.04 seconds. So okay duration, they're all right there. PR interval, our PR interval, if you look at our PR interval, is greater than 0.2 seconds on each of these, and that is consistent from beat to beat. So it's greater than 0.2 seconds. QT interval is okay for what we're looking at. And then the dysrhythmia, we know we're looking at first degree because of the rules we applied with the block. So it's not a normal sinus rhythm. It is a first degree atrioventricular delay. It's not atrial fibrillation, and it's not second degree type 2. So now let's take a peek at this one. So if we go in here and we see that we've got our ventricular rate, so we'll look at our ventricular rate 1, 2, 3, 4, 5, 6. These are potentially, so maybe 8. Our atrial rate 1, 2, 3, 4, 5, 6. Our rhythm, because of these things here, we have an irregularity to it. P waves are okay. The QRS complexes, when they show up, for the most part, those that are conducted have about a 0.04 second duration. Your PR interval is normal or less than 0.2 seconds. QT interval is okay. The dysrhythmia, well, this is a sinus rhythm. It's not a normal sinus rhythm because you got these blips right here, but it's a sinus rhythm when these are called PVCs, which are premature ventricular complexes. Some texts will refer to them as premature ventricular contractions, but these are PVCs, premature ventricular complexes. So this is a sinus rhythm with PVCs. So if you're palpating a pulse and you feel it, boom, boom. So here, if we're palpating this individual and they had an A line in, and you could say that you would feel boom, then nothing, boom, boom, nothing, boom, boom, boom. As far as what you're feeling, if you're palpating the radial artery, like if you're getting ready to do an arterial stick or something of that nature. So PVC would be a premature ventricular complex. Now we'll look at this one in pretty good detail. So you notice it's upside down. I would imagine that the overall wave of depolarization is moving away from the positive electrode, which is this. So this could potentially be lead AVR. Let's look at our ventricular rate. 1, 2, 3, 4, 5, 6, 7, 8, 9 is 90. Atrial rate 1, 2, 3, 4, 5, 6, 7, 8. That does, I mean, it's not bisected, so you get pretty much the whole thing. So we're going to call it. So you got an atrial rate of 90. The regularity is regular. P waves are good and normal. QRS is 0.8 seconds. It looks like 2 small boxes. The PR interval is less than 0.2 seconds. QT intervals are okay. Our dysrhythmia, there's no this is an NSR or a normal sinus rhythm here, assuming your patient has a pulse. If this patient did not have a pulse, you could be looking at pulses, electrical activity. So does the patient have a pulse? Yes, patient got a pulse. This is a normal sinus rhythm. Now let's look at what we've got here. So this looks a little bit different than kind of what we've seen already, but we'll take the same approach. Does the patient have a pulse? Yes, the patient's got a pulse. What's our atrial rate? P waves, 1, 2, 3, 4 is 40. Atrial rate, 1, 2, 3, or excuse me, the ventricular rate, 1, 2, 3, 4 QRS complexes. So that's 40. Those match up with one another. It is regular. It's slow, but it's regular. P waves appear to be normal in shape and size. QRS duration is right around 0.4 seconds, 0.04 seconds. So we're good there. Your PR interval, though, if you look at your PR interval, that extends out greater than one large box. So it is greater than 0.2 seconds. And that is consistent from beat to beat. So we know that we got first degree atrioventricular delay. So let's look at our answer to sinus bradycardia. Some people would jump on sinus bradycardia because of the slow rhythm, but because of that prolonged PR interval that's consistent from beat to beat, this is not just sinus bradycardia, so that's wrong. Third degree AV block doesn't match third degree AV block. Looking at sinus rhythm with first degree atrioventricular delay, it is a sinus rhythm, but that would kind of fall more if we were between 60 and 100, so we'll roll that out. So if I were taking this test, I would roll with a sinus bradycardia with first degree atrioventricular delay, because we're applying what we know about the ECGs to the overall setup of everything. Now, again, let's go through this one. Look at the overall atrial rate: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So it's 120. There are 12 R waves as well: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 120. Regularity: it is regular. P waves are normal in shape and size. Your QRS duration is appropriate. It's less than 0.12 seconds. PR intervals are okay. They're good. They're less than 0.2 seconds. They're less than 0.2 seconds. QT intervals okay. The dysrhythmia here, so it is a sinus rhythm. You got a P wave in front of every QRS complex. This is sinus tachycardia. Sinus tachycardia. Now let's take a peek at this one. Same thing. Does the patient have a pulse? Yes, patient's got a pulse. We will apply the atrial rate is 40. Ventricular rate is 40. The regularity appears to be regular. P waves are normal in shape and size. QRS complex is less than 0.12 seconds. Our PR interval, we look here, it's going to be 1, 2, 3, 4, 5 boxes. 1, 2, 3, 4, 5 boxes. 1, 2, 3, 4, 5 boxes. So we are less than 0.2, or we're right at 0.2 seconds. The QT interval okay. So looking at this, don't let the fact this is trending up mess with you. This could be some variation with breathing or anything to that effect. It's not a normal sinus rhythm because your rate's less than 60. It's not a junctional escape rhythm. It does not meet the criteria for second degree atrioventricular block type 1. So this is a sinus bradycardia rhythm. Sinus bradycardia rhythm. We've already looked at this. This is uniform in shape. There are no discernible P waves. This is a monomorphic ventricular tachycardia. This is a ventricular fibrillation. So this is going to be what you get with ventricular fibrillation. You got to start high quality CPR, get chest compressions going with the individuals here, and then defibrillate as soon as possible, because you always defib the VFib. So this is ventricular fibrillation. It's just not a good thing to be in. If we look at this particular rhythm, again, you've got P waves by themselves, so we know that we're looking at some kind of a block. Based upon everything that we've talked about already, you can establish that there's not like a normal pair. So I would go again that this would be your third degree. Now this one's talking second degree type. Let's look at that. So 1, 2. Okay. All right. So we do have, so looking at it a little bit quicker, you do have prolongation of the PRM until you get one that drops off and then it lengthens out again. It would be nice to see a further strip to make sure that that pattern remains consistent where you get longer drop. But we'll go with second degree type 1 here. We talked about needing to be able to analyze those rhythms and go over those relatively well. You're going to need to be able to do that for your final exam. Those will be moving. So you get to look at a moving rhythm for 20 seconds, and then it'll stop for like 10 seconds, and then you write down what your answer is. So that's important.